All right. Good morning, everyone. Thank you for joining us. My name is Dr. Savannah Clary, and I'm a clinical pharmacist at Aegis Sciences Corporation. I will be presenting today's webinar, which will be focused on specific types of drug interactions. On their own, medications are capable of individually causing side effects and adverse drug events for patients, but in combination, there can be additional concerns. Some drug interactions are pharmacodynamic, leading to clinical effects that can range from mild to life threatening. And in today's webinar, we will address three common and potentially very serious pharmacodynamic effects that can result from drug interactions: QTC prolongation, serotonin syndrome, and tardive dyskinesia. Our objectives for today are to define QTC prolongation, serotonin syndrome, and tardive dyskinesia, list examples of medication classes that put patients at risk for these adverse drug effects or ADEs, describe factors that may increase the risk or severity of these ADEs, and finally, understand the role of InterACT RX testing in helping identify interacting substances capable of causing these ADEs. Because some combinations of medications can lead to such serious drug interactions, patients taking multiple medications may need to be evaluated for drug drug and drug food interactions, or DDIs, in an objective manner to allow for consideration of recently ingested substances. Reliance on traditional methods of identifying DDIs, such as patient reported home medication lists or data in the patient's medical record or pharmacy record, or data from the state prescription drug monitoring program or pharmacy claims data, may not provide complete data, which can allow unknown medications to continue to contribute to unevaluated DDIs. Unfortunately, a drug interaction is not identified in some cases until the resulting ADE occurs. We will review each of the three syndromes that we introduced at the beginning of the webinar, and then we'll look at a patient case toward the end of the presentation to see how each of these could potentially come together in clinical practice. So we'll start with QT prolongation. The QT interval represents the ventricular function of the human heart, and this is expressed as a measurement in milliseconds. When the value is corrected using the patient's heart rate, it is referred to as a corrected QT or QTC interval. QTC prolongation is a measure of delayed ventricular repolarization, and this may be indicative of patients at risk for a potentially life threatening arrhythmia. The normal QTC interval for men is 440 milliseconds, and for women is slightly longer at 460 milliseconds. A patient may be at increased risk for arrhythmias when the QTC interval reaches greater than 500 milliseconds, especially when they have had a normal baseline established already. A change of more than 30 to 60 milliseconds from their baseline occurring after the initiation of a new medication or following a dosage increase may also be indicative of a patient who is at risk for arrhythmias. Several factors can increase a patient's risk for QTC prolongation. These risk factors are important to consider during the process of evaluating a patient's current therapeutic regimen. These include female sex, reduced heart rate or bradycardia, electrolyte abnormalities, renal dysfunction, and these are in addition to the drugs that prolong the QT interval. Healthcare systems have attempted to implement clinical decision support tools to help alert providers of patients that would be at the highest risk for adverse effects associated with drug induced QTC prolongation. Unfortunately, it's very difficult to do a comprehensive review of the risk factors for QTC prolongation. For this reason, utilizing a tool such as InterACT RX to determine the presence of medications capable of causing QTC prolongation can really help in managing drug interactions as well as reduce the incidence of co prescribing medications with this additive adverse effect type profile. The ventricular arrhythmia most often associated with QTC prolongation is known as torsade de pointe or TDP, which translates from French as twisting of peaks, and this can result in sudden cardiac death. Identifying potential causes of drug induced QTC prolongation during treatment may allow providers to mitigate the risk of life threatening arrhythmias such as TDP. The Arizona Center for Education and Research on Therapeutics has developed an online database called Credible Meds to compile information about drug induced QTC prolongation. This database stratifies individual drugs into 4 categories based on the level of risk and defines those categories as follows: So it starts with drugs with known risk of TDP. So these drugs are known to prolong the QT interval and are clearly associated with a known risk of TDP, even when taken as recommended. So some examples here are citalopram, fluconazole, and methadone. Then the next level down is possible risk of TDP. So these drugs can cause QT prolongation, but currently lack evidence for risk of TDP when taken as recommended. Some examples here are nortriptyline, clozapine, and tizanidine. Then there are drugs with conditional risk of TDP. So these drugs are associated with TDP, but only under certain conditions of their use or by creating conditions that facilitate or induce TDP. And so some drugs in this level of risk are olanzapine, diphenhydramine, and trazodone. And finally, there's another level of risk, and these are drugs to avoid in patients with congenital long QT syndrome. So these drugs pose a high risk of TDP for patients with that syndrome and include all the above categories plus some additional drugs that don't necessarily fall into the above categories, but have a special risk because of other actions. So any of the above drugs could be mentioned here, but some that specially fall into this category that wouldn't otherwise be mentioned above are amphetamine and methylphenidate. So please note that these example drugs that I mentioned are just a few isolated examples only. I do recommend visiting the credible.meds.org website for more information on many more QTC prolonging medications in each of these risk categories. It's a very helpful tool to check out. InterACT RX testing identifies recently ingested substances in the urine or oral fluid of patients and analyzes the present analytes via the supporting drug database, which is powered by First Databank. And then, if a risk for QT prolongation is identified, this will be provided in the clinical description of the interaction, which is reported by InterACT RX. And so the results can then assist in identifying the presence of the medications capable of causing QTC prolongation, helping manage the drug interactions, and reducing the incidence of co prescribing medications with this particular additive adverse effect profile. So, drug interactions identified by InterACT RX reports are solely meant to supplement the knowledge base of the healthcare provider when making patient related decisions. And then, if an interaction is identified that may place a patient at risk for QTC prolongation, a comprehensive review of all home medications and other predisposing risk factors may be warranted. In those patients that appear to be at high risk for cardiac events associated with this adverse effect, an ECG may be required to further evaluate the QTC interval. So now we'll transition to serotonin syndrome. Serotonin syndrome is an ADE that's precipitated by ingestion of substances that increase serotonin concentrations in the central nervous system. The occurrence of serotonin syndrome is directly tied to the concentration of serotonin in the central nervous system. Symptoms related to this ADE include the following: neuromuscular excitation, which can manifest as muscle spasms and rigidity; autonomic nervous system excitation, which can cause increased body temperature and heart rate; and altered mental state, which can result in agitation and or confusion. Milder cases of toxicity associated with serotonin syndrome generally resolve with removal of the offending agent, and symptoms of serotonin syndrome are generally most likely to appear shortly after the initiation of therapy or after an increase in dose of a serotonergic agent. When evaluating an individual's risk for serotonin syndrome at initiation of therapy or when adjusting the dosage of a serotonergic drug, it is important to understand which classes of drugs may place patients at the highest risk for adverse effects. Prevalence and severity of this interaction are often influenced by the medications or drugs that are involved. Psychiatric illnesses, for example, should be carefully evaluated for serotonin syndrome at the initiation of therapy or when medication doses are titrated. Behavioral health medications that specifically target serotonin receptors may escalate the risk of these adverse effects. Due to their mechanism of action, behavioral health medications may be implicated as the major causative factor in serotonin syndrome. Selective serotonin reuptake inhibitors, or SSRIs, serotonin norepinephrine reuptake inhibitors, or SNRIs, tricyclic antidepressants, or TCAs, and monoamine oxidase inhibitors, or MAOIs, may all increase the risk of serotonin syndrome, although MAOIs have fallen out of favor for treatment of behavioral health conditions largely due to their adverse effect profiles. Other examples of serotonergic medications include anti-migraine medications, some over-the-counter medications, some illicit drugs, and some opioid analgesics. When InterACT RX results are available, if an interaction between serotonergic medications is identified and a patient has been stable on each drug that is part of the interaction, then changes to currently prescribed medications may not be necessary. However, identifying an interaction may be especially helpful to providers that are preparing to adjust doses of medications, specifically in patients that are already on multiple serotonergic agents. Again, Interact RX are meant to supplement the knowledge base of the healthcare provider. And when an interaction that may potentially result in serotonin syndrome is identified by Interact RX testing, patients should be addressed for each of the previously discussed signs and symptoms of possibly having serotonin syndrome. It's also important to rule out other potential drug induced syndromes with similar adverse effect profiles, particularly neuroleptic malignant syndrome or NMS. Although NMS and serotonin syndrome present similarly, the treatment and risk of adverse outcomes differ. Severe toxicity associated with either syndrome is considered a medical emergency and will likely require intensive medical treatment. In addition to considering how concurrent usage of medications that cause release of serotonin may evoke adverse effects, one must also be aware of how drug interactions or genetic predispositions affecting metabolism may also factor into the occurrence of this ADE. Reduced metabolism of an active serotonergic drug and resulting elevated concentrations may also lead to increased potential for adverse effects. The final syndrome that we will cover today is tardive dyskinesia. The term tardive dyskinesia literally means a slow onset movement disorder with a range of possible movements, severities, and permanency. The involuntary muscle movements associated with this phenomenon can be a slight tremor or involve uncontrollable movement of the entire body. Any part of the body may be involved, including the face, lips, tongue, trunk, and extremities. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition or DSM 5, further specifies that TD persists despite discontinuation or change of the medications, and that diagnostic confirmation can take place after symptoms have persisted for more than 1 month following discontinuation of the medication. TD is most often associated with dopaminergic antagonist medications such as antipsychotics, but it can also develop with many other classes of medications as well. There are additional risk factors that may further predispose a patient toward the development of TD, although there is not equal agreement in the literature about contribution of these, such as medication related risk factors. This can include use of both typical and atypical antipsychotics. According to the literature, the reported cumulative annual incidence of tardive dyskinesia is much lower with second generation or atypical antipsychotics compared with first generation or typical antipsychotics. Also, use of lithium and or anti-Parkinsonian agents may predispose someone to the development of TD. There are demographic risk factors such as older age, female sex, and African or African American race. There are cognitive risk factors such as previous brain injury, cognitive disturbance, dementia, or pre existing mood disorder. Early extrapyramidal symptoms may predispose someone to the development of TD, and then some disease states have been postulated in the literature as risk factors, including diabetes and HIV. And then there are several pathophysiologic pathways that have been proposed as contributing to TD. However, none of these are considered universally accepted, and the etiology may be multifactorial. These are examples of several that were postulated across several articles that I reviewed. Some are related to prolonged blockade of postsynaptic dopamine receptors, NMDA receptor excitotoxicity, neurotoxicity. There's several different pathways that have been proposed, and again, none are considered necessarily universally accepted, and several may play a role to a certain degree in the development of tardive dyskinesia. When InterACT-RX testing identifies interacting medications with the clinical effect of an increased risk of TD, the clinician may evaluate the therapeutic indication for each medication. Some DDI scenarios resulting in increased risk for TD may come from duplicate therapies. The DDI scenario may also involve a medication that was perhaps prescribed for a short term need, and the patient has not understood the limited time frame that they were directed to take the medication, and they've perhaps continued it beyond the time frame that they should have. Reviewing the patient's InterACT RX results against their medication list with the patient to help match up current prescriptions with current diagnoses is essential to help resolve duplicate therapies and provide optimal patient medication education. Then, any changes to the medication regimen to help resolve DDIs and address TD symptoms can be made with consideration of the correct and current medication list. Again, InterACT RX results are meant to help supplement the knowledge base of the healthcare provider. A complete review of the patient's home medications, including over-the-counter and herbal medications, may be warranted to see, what interactions may be existing or what substances may be contributing to the development of TD symptoms. Further clinical assessment of TD is supported by the Abnormal Involuntary Movement Scale, or AIMS, and the Schuyler-Kane Research Criteria, the latter being used to identify probable antipsychotic induced TD and has specific criteria related to the establishment of that. Before we wrap up today, let's look at a patient case to see how interacting medications can find their way to a patient and how these pharmacodynamic interactions can manifest. So here's our case. MJ is a 61-year-old female who recently presented to her primary care provider for a mid-year checkup. Her past medical history includes major depression, neuralgia, and insomnia. She states that she has had new onset pain in the past 2 weeks after a recent fall at home and uncontrollable shaking of her legs that resulted in a trip to the emergency room. MJ claims that she has been taking her medications pretty regularly and is worried that her side effects may return. The provider is very concerned about the patient and would like to find out more information before initiating a treatment plan or adjusting her current medications. The patient is currently prescribed gabapentin, paroxetine, promethazine, and trazodone. MJ's primary care provider orders medication adherence and drug interaction testing. The results of this definitive testing confirmed that the patient was ingesting her prescribed medications. However, the InterACT RX test also identified recent ingestion of metoclopramide and ciprofloxacin. The use of metoclopramide and promethazine are contraindicated as both drugs can increase the risk of tardive dyskinesia. Additionally, the InterACT RX test detected drug combinations that could put the patient at risk of serotonin syndrome, and that combination being paroxetine, metoclopramide, and trazodone, and QTC prolongation with the combination of trazodone and ciprofloxacin. So this sample report below shows what this would look like on an AEGIS lab report. So it shows the pair of interacting substances on the left, the interaction severity in the middle, and then the clinical description of the interaction on the right. After discussing the results with the patient, the primary care provider discovered that this patient had previously visited a community care center for complaints of chest tightness, and that was diagnosed as gastroesophageal reflux disease, or GERD. The provider at the community care center had prescribed the patient metoclopramide. InterACT RX was able to identify that the patient was ingesting this medication that is contraindicated for patients who are also taking promethazine. So, based on the results of InterACT RX, the provider was able to take the following actions. The primary care provider discontinued the metoclopramide and transitioned the patient to a more appropriate therapy for GERD, as tardive dyskinesia can develop into a permanent condition. And furthermore, the provider was also able to counsel the patient regarding her new medications and reinforce the dangers of drug-drug interactions. So, to summarize our application of InterACT RX testing from today's webinar, InterACT RX testing allows providers to add on definitive testing for commonly prescribed medications in urine or oral fluid to allow for analysis of the positive results alongside positive results from medication adherence testing. And this analysis, in conjunction with the data from First Data Bank, allows for at a glance review of interacting pairs of medications, the severity of the interaction, and a description of the clinical effects of the the interaction. So, as we saw today, this may include an increased risk for QTC prolongation, serotonin syndrome, tardive dyskinesia, and many other pharmacodynamic or pharmacokinetic DDIs. InterACT RX results are intended to be used as a tool within a comprehensive approach to help ensure that optimal medication reconciliation and review is achieved. If you have questions about today's webinar or InterACT RX testing in general, please contact your regional sales manager or the Aegis clinical team at the phone number and email address on your screen. And we want to thank you for joining us today. And this concludes today's webinar presentation. Have a great day.